Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
George, when this goes to air, it would have already happened. But right now we are in the future and I'm really excited because I'm about to fly off to the Gold Coast and so are you.
Yes. It's the big Aging Australia National Conference is on the Gold Coast from the 30th of September to the 2nd of October. So you're probably hearing this after the event. It's basically a collection of about 3,000 aged care providers getting together and talking about a whole range of topics. And the timing is pretty important at the moment because the new Aged Care Act comes into place on the 1st of November. And a couple of days ago, the ABC had a big story about aged care. And a week before that, aged care was getting blamed for the bed blocks in hospitals. So there's a lot happening in the aged care space that needs to be worked on. And innovation and technology is one of those tools we really need to get into place here.
Oh, that's cool. I actually didn't realize how big the conference is. And and we've got a dinner that you're hosting and I'm going to play backup dancer or something.
Yes. We're looking forward to hosting a dinner with our friends from Connected Health and looking at that issues around the use of technology in aged care. And I'll put in an early plug for the ITAC conference, which will be in May next year in Brisbane. So get people to start putting it in their diary. Other than preparing for Gold Coast, what else have you been up to? Getting your sunblock ready?
Yeah, I've been traveling a lot and I've got heaps of work on at the moment, which is, a good thing when you work for yourself, but it's all going well. But I must say, I can't remember the last day, especially with all the personal stuff that's happening and work. I can't remember the last day I didn't have my computer open. So I'm spending this weekend 2 days in the Gold Coast. I'm going to go up early. I decided I deserved a break and going up early. And I have 3 novels, which, I'll be lucky if I get through one of them because it's like over 1,000 pages, one novel. But anyway, I've got 3 novels on my Kindle and I've also got a digital health book that I'm going to read as well because we're interviewing the author for our next show. So stay tuned, listeners. So we've got another book author coming up. So I'm going to read that as well. And, not set an alarm. Looking forward to that, George.
Or make sure you put your sunblock on when you're sitting on the beach reading those books.
Oh, definitely. Yes, do not leave the house without it. And George, just on the aged care theme, there's so much stuff in the news about aged care. And you've been pointing out the language that keeps getting used and just how disrespectful it is to older people and indeed to the people who also work in aged care. So I just wanted to call that out because it's complete BS. It's like people don't even notice they're using that language. I mean, surely it can't be deliberate. But I just wanted to say thanks. Thanks for calling it out.
I appreciate that, Louise. We understand there are challenges in delivering aged care in Australia. We understand that the population demographics are changing, but putting the blame on those who have been through wars and famines and recessions and depressions and, when they hit their 80s, all of a sudden pointing the finger at them and blaming them for living long enough to require care is a major problem. So I think we really need to put it in the context that these are the people that actually built this country and did a lot to support us to get us where we are now. And we owe them the right to a good aging experience.
Absolutely. Yeah. So thank you, George. Okay. Well, I'm looking forward to seeing you, but I suppose we should get to our hot topics.
We should.
All right. Well, we're kicking off today's first hot topic with a topic we like to revisit on the pod, misinformation, the slow burn infodemic that health professionals grapple with on a daily basis and which social media platforms love to propagate. Scott Galloway, he points out that in marketing, the mantra for a long time, like forever, was sex sells. But he says that social media companies have worked out something that sells even better, rage. In this attention economy where accuracy isn't prioritized, only clicks, we really need to radically change how we battle misinformation. So, friend of the pod, Tina Purnat, is co-author on a new article in the Lancet Primary Care that argues health professionals must be more active in stopping falsehoods and need to adapt to this new information environment. Tina and the authors suggest 5 roles for healthcare professionals to help patients navigate the modern information space. So, educator, curator, co-navigator, advocate, and also being a reflective practitioner. And I just thought it was good timing to have this conversation, and great for Tina and her co-authors to put that out, because just look at what happened last week. This complete fiasco, the US president blaming paracetamol causing autism. Completely untrue. Within 24 hours, health systems worldwide, like if you read the American press, you think it just impacts them. And it's like, no, people, this has become a global problem now. So worldwide, people drop everything to mop up this mess, issuing clarifications, answering panicked patient calls, preparing statements, the list goes on. So I asked ChatGPT to help me estimate how much time and money would have been spent in just the first 24 hours. The conservative estimate, and I think this is very conservative, was between 6,000 and 30,000 staff hours were wasted globally. That's the equivalent of nearly 2 years of professional labour just to correct one lie. And it also estimated that it would cost more than $2 million. This was just in 24 hours. And of course, that's not taking into account the family anxiety, social media chaos, the long-term erosion of trust. And I typed this up and put a post on LinkedIn about it. And yeah, it already has had over 4,000 impressions. And I also saw that the president of the Australian Medical Association posted her experience at the end of that day, where she did over 12 interviews, and her post has received over 2,500 likes. It's been reposted 245 times. You know, this and so much more is just time and money pulled away from real care. Misinformation, it's not just an abstract threat to trust, but it's really an operational and financial burden on health systems. So Tina's paper argues that we need systems that flip the script, rapid amplification of expert voices, accountability for platforms, investment in health literacy. Otherwise, health professionals are going to be stuck cleaning up after politicians and influencers instead of treating patients. Sorry for that long intro, George. What are your thoughts on this? It's just been a mess.
Look, I mean, the timing of this paper is impeccable. I can reflect on that. I've had dozens of people call me about the paracetamol question and ask me about what the correlation is. The data does not show what the president and the secretary of health and disappointingly, even a medical doctor, Dr. Oz, were up on stage saying about paracetamol. So again, the evidence is quite clear that paracetamol in pregnancy is safe if taken as per instructions. I mean, paracetamol can be a dangerous drug if taken in excess. If you take 20 or 40 paracetamol tablets together, it's a problem. But in properly used dosage as required, and as highlighted by many clinical specialists, the risk of high fever in pregnancy is significantly greater than any potential risk of paracetamol. And that's one of the key indications for taking paracetamol in pregnancy. So again, really important that we focus on the evidence. And I look back in 1997, Tricia Dreenhout from the UK, she published a series of papers on how to read the medical literature. These are basic papers that every clinician has probably been exposed to over the last 30 years. I remember back in the 1990s when they first came out, they were pushed out to all junior clinicians back then. Evidence-based medicine is not a new idea. It's been around for a long time, and we need to make sure we stick to it. Tina's work is critical in this space. I mean, she does highlight that clinicians have to take on these roles of being a curator and educator.
How do they do that though, George? Because it's not like it's being forced upon them, but then how do we even make that happen? Because poor clinicians, and they made that point in the paper, we're not just saying, oh, it's all up to the clinicians, you need to fix everything. It's like, how do we support clinicians to do this?
Absolutely. And the reality is, do we need specialized clinicians to play this role? And we've seen in the United States, the HHS has cut a lot of the roles in people like the NIH and those sort of research groups. This is why we need academic clinicians who can spend time analyzing the data and publishing it in a way that's usable by people. We probably need a better way of making that data available. We do have some great websites that make medical data available to lay people. They also point out that we need to make sure that it doesn't become a doctors versus consumers type debate, that the bad old days of the paternalism, now I'll tell you what to do and you'll do it, moves away. But shared conversations on a common ground. Now, we've seen lots of interesting things over the last couple of weeks. The Jimmy Kimmel experience comes to mind, that if you say something which people disagree with, the repercussions become quite significant. So hopefully our podcast doesn't get Jimmy Kimmeled. But I think we really need to highlight that there is a science behind this that needs to be followed, and we can't take shortcuts.
No. And my apologies to you, George, but Tina's put out another article and I just saw it a couple of hours before I went to bed. So it's in the Health Promotional International Journal. I'll put a link in the show notes, of course. And it argues that the information environment must be treated as a determinant of health. So treating it the same as like clean water, housing and air. So it's actually an infrastructure that shapes whether people can live healthy, secure and thriving lives. That paper calls on public health to rethink its positionality towards the environment and to take active steps to reshape it, which I completely love. And a quote from the article, Tina wrote, "The Ottawa Charter once said health is created where we live, work, pray and play. In 2025, that must also include where we scroll, search, stream and connect." I thought that was just really well said. So I'll send you a link to that paper, George, and I apologise that you haven't seen it before.
I think that's a beautiful quote. And the reality is, I mean, in Australia, we're now bringing in legislation to make social media not allowed to be viewed by people under the age of 16. I think we need to make social media more responsible. I mean, just because there's a TikTok video of someone dancing and saying paracetamol is bad is not the same as having a meta-analysis paper in a peer-reviewed journal. I mean, influencers didn't exist when I was young, and at the moment I'm starting to worry that the influencers may be providing the wrong influence to many people in our country.
Oh, well, get this example. Sorry, we will move on to a new topic, people. But it blows my mind. I was listening to a New York Times article the other day. It was about young women in their 20s taking themselves off birth control because influencers have told them that, oh, I lost weight when I went off the pill, and I feel more like me, and and saying they had all of these health impacts. So young women are taking themselves off the pill, and of course the article interviewed women who 4 months later they're bloody pregnant, which was not on their plan. And so now they're going to be a mum because it just blows my mind. Like the pill that's been around since the 60s? Like we have a lot of evidence, it works.
It's demoralizing that, you speak to many young people and their aspirations to become an influencer. You get, no, become a researcher and influence with real data. Don't influence with stupid TikTok videos.
Brilliant life advice. Brilliant life advice, George. Okay, well, I'll get off the soapbox now, George. Let's go to a new topic. Now, wearables, they've been around for a long time. And I had a look back at my little collection of stuff in my drawer and I realized I got my first wearable in 2010, which was a Fitbit. Some of our listeners would be too young. There used to be like this little clip thing and put it on your jeans, or women would often put it on their bra. And so that was 2010 I've had wearables. What about you, George? Because I know you'd have a collection in drawers somewhere.
I do have one of those old clip-on Fitbits floating around, and I also had the Fitbot Zip, which was a little one you tied around your neck. I mean, but going even further back, I mean, I used to have a pedometer back in the 1980s, 1990s. We used to do these little mechanical things. And
always so cutting edge.
And you do know that, I mean, the history around the pedometers, because the 10,000 step thing we hear about was actually a marketing ploy devised by a Japanese pedometer company who produced the first pedometer in the 1960s. And the 10,000 steps has nothing to do with physiology or health. The Japanese symbol for 10,000 looks like someone walking, and that was basically the way they promoted the idea of a 10,000 steps.
Oh my God.
It's been around for a long time. Look, I'm a big fan. I'm like you. I've got a drawer full of wearables. Every time a new one comes out, I know now you wear an Apple Watch. I wear a Samsung Watch 7. So we've covered both sides of the spectrum there. And I love my watch. I mean, it's annoying that I have to charge it every day or so, but I mean, the data it gives me is amazing. And, I think it's a great tool, but we need to understand what we do with these tools.
Yes, well, a report actually that you found, and thank you for sharing it. I thought it was really interesting. So the report is from the NEJM, so the New England Journal of Medicine Catalyst Insights report about wearables. And the report surveyed more than 600 clinicians worldwide. So look, it's a decent size, but when you're looking globally, it's not that big. But anyway, they found that adoption of wearables in chronic disease management and remote monitoring has skyrocketed. And clinicians were reporting improvements in patient engagement, early detection, and chronic disease outcomes. And they asked as well, what's holding up further adoption? And no surprise, it's really the stickiness of traditional business models that haven't innovated to include wearables. The survey found almost 90% of devices are self-paid by patients, even though the majority of clinicians say that insurers should fit the bill. Other barriers cited the lack of integration into EHRs or EMRs and clinician workflows, with fewer than 40% of providers trained to use use wearables. That seemed crazy high to me. I'm like, I don't think I know a single clinician that would have been trained on how to use wearables. But anyway, so what did you think of this report, George? And do you think that wearables, they offer so much potential to become the backbone of proactive medicine, especially now they're getting regulated and, it's not just a gimmick anymore with your 10,000 steps that looks like the Japanese letter for walking?
Look, I mean, this report was interesting, and I'll have to admit, I think I was one of those 600 clinicians that they surveyed, which is how I got the report. The patient engagement component, I think, is probably the most important thing. The fact that people are now looking at simple things like their pulse rate when they go for a walk versus when they're sitting down, what their resting pulse rate looks like. The fact that some of these watches can now do things like oxygen saturation. They can even do ECGs, whether people should be looking at their own ECGs. I mean, I went to med school for 5 years and I still have struggled reading an ECG. But hey, the reality is things like atrial fibrillation, which is 1% of the population, but has significant health consequences, can be picked up now by these devices. I think we're finding more use models for them. But the patient engagement part, I think, is the important part. As more people understand about their own bodies, the better the conversations they can have with their healthcare providers to optimize their own body. So I think that's a good start. We originally tracked steps. Steps was a great thing, and we all became quite pedantic about our steps. But now we're capturing a whole bunch of things. So I think it's important. The fact that RFK Jr. said that everyone in America should be wearing a wearable in the next couple of years is an interesting discussion point. I mean, there's so many other problems in American healthcare. I'm not quite sure wearables will solve all those issues. But if we use it as an education tool, if you share the data, the biggest challenge has been is how do you share that data with your clinician in a meaningful way? Because seriously, if you're a GP with 2,000 or 3,000 patients on your books and every day you get a report of their resting pulse rate, I'm not quite sure what you're going to do with it. So we need to think about it. But interestingly, when you look at at-risk patients, and I think this is the really important thing, is that if you're used to using a wearable when you're young and healthy, when you get older and you need care, you don't have to then learn how to use that device. So making it the norm, and let's be honest, the Apple Watch and the Samsung watches are pretty ubiquitous nowadays. Any event I go to, I haven't seen many people with an old analog watch for a while now. They then become much more essential. So if you get people who are in heart failure, people who are in atrial fibrillation, then being able to use those tools and not sort of being put on their wrist at the age of 80 and sort of said, here's to work with, I think that's probably the most important part. Whether insurance needs to pay for it, I mean, let's be honest, the prices have dropped pretty remarkably. So you can actually get some reasonable smartwatches nowadays for reasonable prices. But from an equity perspective, we need to think about how do we make sure the people who need them get them.
Yeah, but it's great to see more people doing research on and actually utilising these devices as a clinical care tool and for remote monitoring. So yeah, I'm sure there'll be further reports in the future which we can report back on.
And the other buzz is this idea of digital biomarkers. And it may not just be your pulse rate, but it may also be your heart rate variability, and it may well be your response to exercise. So there's a whole bunch of parameters we can capture here. I think the fact that we're capturing data, feeding it into these new tools that we have to analyze the data, looking for things that may make a difference, it's not fit for everyone, but there have been reports of people who identified that they were in atrial fibrillation thanks to their Apple Watch. And that makes a big difference because atrial fibrillation, if untreated, can lead to cerebrovascular accidents, to strokes and death. So it's a good thing we can catch it early on devices that cost a couple of $100, whereas previously we had to put a Holter monitor on and monitor you for 48 hours. And even that wasn't accurate enough because atrial fibrillation can pop up and disappear very quickly.
Yeah. My dad would occasionally be given one of those monitors to wear. And of course, because he wanted to get good results, so he'd spend the day just sitting on the couch. And I was like, Dad, trying to be smarter than the system when it's trying to help you. I don't know. That's the best strategy. But anyway.
That's a common thing, and people that we don't want to upset the doctor with a bad result. So we'll make sure we don't do anything. So it looks good, better than what it is.
Yeah, exactly. Okay, well, George, for our next hot topic, Australia has had a real moment on the world stage, and I just wanted to sing it out loudly. Time Magazine's 2025 list of the world's top health tech firms just came out, and it features 9 homegrown companies: Harrison AI, Lumery, Mabel, Magentis, MedAdvisor, Health Engine, Lenexa Medical, ResApp, and Osara. Together, these companies, they really span the spectrum of health innovation. So we've got AI diagnostics, disability and aged care platforms, patient booking systems, medication adherence, and even smart hospital beds. Now, I had a look at the criteria because I, was wondering, do these guys just, do they have excellent PR marketing teams, or how does Time work it out? But Time said that each company makes the list because they've moved beyond pilot projects into products with real world impact. They need to be scaled internationally, raising significant capital, or being acquired by global players. So I just thought this was so cool. What do you think of this one, George? You would know a lot of people at these companies, as do I.
Is this where we start calling out Aussie, 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 oi, oi, oi? I mean, yeah, I think it's fantastic. I think it's fantastic. And you're right. I'm looking at that list of companies. I think I've met with all of those over the years, and they've done some amazing work. And the fact that they've done it in Australia, often with very limited resources compared to startups and companies in the United States, is great. I mean, I won't go through them all, but I mean, Osara, which used to be Cancer Aid, I remember I was at their original pitch at Sydney University back in mid-2010s before they went on Shark Tank, and they've got quite an interesting story how they've progressed over the years. Lenexa Medical, their smart hospital beds now being used a lot in aged care. Mabel was a game changer in the way it changed the way that we had access to healthcare professionals.
So on Mabel, so I'm at my, because Dad died, and between him dying and the funeral, there's like a good month. It took ages. But anyway, so the point is I was spending a lot more time in the small country town where I'm from. And the amount of times, George, people mentioned Mabel to me. And even one of my sister's friends, he's just recently returned back to live there. And he's like, oh yeah, I'm on Mabel. So there's like a lot of small communities. There's a lot of older people. And so yeah, he does people's gardening and that sort of stuff. And yeah, I've never heard so many people talk about a health tech company in my hometown. They all love it.
And I remember very vividly when they first pitched Mabel back at one of the ITAC conferences in Melbourne, must have been back about 2011, 2012. And the industry thought, oh, no, this will never work. We need to have a structured, organized workforce. And the reality is there's lots of areas of care that can be provided by people, and that one-to-one, that gig economy concept is amazing. Going through it, MedAdvisor have done amazing work as far as their medication. Health Engine, remember the bad old days when you tried to make an appointment to see a GP? You had to ring up and they'd sort of say, I've got Wednesday at 3:00 and I can't do that. Okay, well, I've got Monday, Tuesday. Health Engine and those sort of tools, they just changed that whole model.
Oh, yeah. Like I literally will not go to places that require me to make phone calls. I'll be like, nah, if I can't find them online and do this at 1 a.m. when I happen to remember that I need to make that appointment, I don't go.
So the fact that these Australian companies have done so well, the fact that Time magazine even has a health tech top 200 or whatever it is amazing in itself. It's really shown how the industry has progressed. Back when we first started in this game, Louise, I don't think Time magazine had anything near a discussion around health tech anywhere in it. Kudos to the Australian companies. Interesting, some of them have actually been started by clinicians. So the work you guys do with the Clinician Entrepreneur Program, I think, is important going forward. And hopefully the next time it comes around, we'll have a few more in there. The key, of course, is what they deliver. And if you look at all those companies, they all do deliver a service which is needed. So I think it's great.
It's so good. All right. Well, it's time for a quick break. And when we come back, we've got some juicy hot topics to delve into, including a study on what clinicians really think of their electronic medical records. Stay tuned. Welcome back, everybody. Now, George, our next hot topic, we're over to the UK. They have published a large-scale survey on electronic patient record usability, and the results are uncomfortably familiar, let's say. The study gathered feedback from over 1,000 NHS clinicians and found that only 15% rated their EPR, or here we would usually say EMR or EHR, but anyway, the record system they use in the hospital, as easy to use. So that's only 15% found them easy to use. Nearly half reported their EPR slowed them down. 3/4 said it added to cognitive burden. To top frustrations, guess what the word would be in that? The word clunky. Yes, the top frustrations were clunky navigation, duplicative data entry, systems that don't talk to each other. But the report also noted that the issue isn't just about bad software, and I'd say that in inverted commas, but implementation mattered more. So organisations that involved clinicians in the rollout, invested in training and tailored systems to local workflows reported a much higher satisfaction. George, there are still so many hospitals that are running on paper and haven't yet gone digital. Will they take heed at independent results like this in making their investment and implementation decisions? I note the report was done as a collaboration between Class Research and an independent organisation and Ethical Healthcare, and it was commissioned by NHS England. So these are serious players.
It's interesting because electronic medical records are not a new thing anymore. I mean, they've been around for quite a few decades. I mean, back in the 1990s when I worked at Prince Alfred Hospital, we had electronic medical record system, which ended up going across all New South Wales. The challenge has been is that the electronic medical record systems haven't kept pace with the consumer changes that we're used to with the use of technology. So at the moment in Australia, there's a couple of dominant players and technology has been questioned as far as how up to date it is. Now, I do note both of those big hospital providers, EMR providers, have both come out with new AI-enabled tools, which hopefully makes it better. So maybe this survey in a couple of years' time will reflect that. But the reality is that whilst they may make life a little bit harder for clinicians having to enter the data in, the value of an EMR going forward has not been challenged. So I don't think any clinician who is on an EMR system will often say, gee, I wish I could go back through 3,000 pages of notes to find what Mrs. Smith's complaint was back in 1993 when she came to the hospital for the first time. So we need to sort of put that in the context that we are adding an administrative burden to clinicians, which is something we need to look at how we do better. And we've had discussions around whether AI scribes and those sort of tools will do that. But the value of having an EMR, and I reflect back, I think it was in 1998, 1999, so very early in the EMR days when I was working at the hospital, we had a computer virus outbreak at the hospital. And I think I can say this now because it's 30 years ago, so I don't think it'll reflect poorly on the system. So we were without our EMR for 2 days. And seriously, I mean, the chaos that caused by not having access to the information at our fingertips and having to go and find physical films and having to go and find pathology results and ring up the pathology lab and to get them to look up on their local system results. So back then, that was one of the things that highlighted to me how important these tools are in that they change the way we deliver medicine for the better. But we need to make sure we improve those interfaces. All those players who are providing these tools need to keep their systems up to date and available. We often hear, if Apple had designed an EMR, it'd be easier to use. Again, there's a lot of information, so I don't know whether you can overly simplify this into a single click a button and away you go type model. But part of it comes down to training. One thing that's come up over and over again with the EMR implementations is that the clinicians aren't properly trained on how to use them. You often discover things about the EMR at 3 o'clock in the morning when you're trying to find something, and proper training processes around the uses of EMRs, I think are probably the key thing here to make sure people have a better understanding of how they can leverage them and use them more effectively.
I mean, certainly, if you haven't seen these systems before and you're looking at them for the first time, they do look antiquated. As a general rule, don't everyone send me screenshots from your system and show me how pretty they are. Some of them are pretty, but a lot of them are not, especially people who grew up natively with software on desktop and or phone. You can tell they haven't aged well in the way that they're designed. Like you said, the systems are working on improving that. It's a big job. But the other thing I thought was the implementation workforce stuff. I can't believe we still do it today, that, we spend hundreds of millions of dollars in a case of hospital systems to buy whatever product or products we want to put in. And for the majority of clinicians, they're not actively engaged in that. They're busy being clinicians. Like, they're not listening to Pulse. I wish they were, but, they're not. They have other interests. So they're just busy being clinicians and they're not involved. And then they get told, Thursday at 2:00, you've got to come to a training session to learn how to use this piece of software, which upends everything that they knew about how they used to do their job and document their job, at least. And there's such an opportunity. What we should be doing is engaging with workforce around these concepts of why we should be looking at innovating and capturing data digitally, the benefits of it for clinicians, for the system, and of course for patients. Because then if people have an understanding where the challenges, and to be honest, let's face it, the things that frustrate and piss them off on a daily basis, a lot of that can be resolved, and that wasted time when you've got information at your fingertips. If they're engaged in that, you'll get less pushback and more engagement in the process. And yet still, like I'm sure the clinicians advocate for that and the managers, but at the end of the day, it goes to someone from Treasury or a CFO who goes, no, I'm not spending all this money. We don't need that much training. And, so they just try and teach them how to use a piece of kit, which is not the point of that kit in the first place.
One of the first experiences I had in implementation management in this space was I was working in a private hospital group that were implementing some electronic medical record type systems. Back in those days, this is back in the early 2000s, the standard monitor that came with a PC was a 14-inch monitor. And we tried to cram a lot of data into that monitor. And I had a lot of people complaining about it. Interestingly, when the next set of PCs came out a year later, they came with a 17-inch monitor, and all of a sudden it became so much easier to use these things on a bigger monitor or on a better monitor or on a higher resolution monitor. So the software is important, but the systems we implement the software on is really important as well. And I've seen lots of experiences where we've tried to cram 5 years of medical data into a laptop screen that's 10 inches across for a 55-year-old who's wearing bifocals and has to bend their neck to 90 degrees to be able to read it. So making sure the tools that we use for accessing the information are fit for purpose is important as well. So that's part of the investment. I mean, you can spend millions of dollars on the software. If you stick it on a teeny-weeny little screen with a teeny-weeny little keyboard that's stuck in the corner of a room on a teeny-weeny little desk, then you don't get, and you'll often hear clinicians talking about their frustrations around the EMR, but it's because they have 35 other frustrations as well. And the last frustration they remember is clicking on the button on the EMR. So
yeah, that's right. And remembering all the passwords as well. Like we had a webinar recently through Pulse IT, and it was very popular because the topic was basically single sign-on. Like, how can you give people one way within the first 24 hours of their job to sign in to all the systems they need? It's not that difficult. You just need the right tools, right implementation.
Single sign-on and systems that link into each other so that when I click on the medical record system, then the right person's radiology type, I don't need to log into the RAS system and type in my name and keyword and then type in the patient's name again and find it again. So context-aware computing was one of the big game changers back in the mid-2000s, 2010s, I think, where they enabled the system. So if you logged into an EMR, it also logged you into the PAS or the RAS or the various other systems. Because again, that became a possibility of error because it was very easy to log into Smith J on the medication chart and Smith J on the radiology chart, but it's a different Smith J unless you compare the dates of birth. So those sort of things need to be managed. It's more than just the EMR. It's the EMR experience that needs to be managed.
Yes. All right. Well, the survey was done originally 3 years ago and the results were really bad. So I think the NHS wanted to do it again, hoping that there was improvement. There wasn't much. So, okay, use that lesson globally and do better. So in our final hot topic today, we're ending with AI. Are you impressed, George? Got through the whole show with only this one AI story. I did a good job this week finding stories that weren't AI.
Great self-control, Louise. That must have been hard. I had to trawl through lots of findings to not get to come up with only one.
There was a lot of hours spent, yes. So this story I'm about to introduce, it rang a bell and I'm like, have we already had this on the show? So I checked old shows and back in July, we discussed the US FDA approval for an AI platform that predicts a 5-year breast cancer risk from mammograms. That's pretty cool. But as reported in Pulse IT, Australian researchers have upped the stakes by unveiling an AI that predicts cardiovascular risk from mammograms. So the same scan designed for breast cancer screening can now double as a heart health check. Right now, it's at the research and pilot stage, but the potential here is huge. One scan, 2 conditions, early warning, all at once. George, I was thinking about how brilliant this is. And once the research is complete, assuming it's proven to work across populations, this needs to become business as usual. But we also know from the literature that it takes about 18 years for new medical treatments and innovations to become everyday practice. And it got me thinking, in the age of AI, do you think we can drastically cut down that 18-year figure and figure out how to integrate new technologies into standard care pathways much faster?
First of all, this is an amazing study, and I take my hat off and give congratulations to the organizations that's done it. And I love the name of this organization, the George Institute for Global Health. It's not named after me.
Another important George.
Yeah, I mean, I don't know whether my parents named me George in relation to this. I don't think so. I think it was around time. But yeah, the George Institute's done some amazing research. This is a classic example of proper evidence-based research being done by organizations. It requires resources to do that. George Institute is a global institute now, but it started here in Australia. It's done some amazing work, and its cardiovascular research in particular has been world-class. So kudos to our Australian colleagues at the George Institute for Global Health. The mere fact that we're able to use multiple pieces of information to gather clinical information that's relevant to a patient is amazing. I think the fact that a mammogram, which we know in itself can be life-saving or can make a significant difference to health outcomes if done early and often, and Australia does have a relatively good screening program around that. But we can then use that information to also highlight other things like cardiovascular disease. The George Institute have done the research to make sure this is not just a correlation type thing. This is more a causation type thing. The more information we have, the more biomarkers we have that are available to the wider population, because we are seeing a lot of stuff happening now where there's a whole bunch of new biomarkers that are only available to people who are willing to pay $5,000 for a so-called longevity test. But, if you're part of your standard screening mammogram, it's important that we highlight the need for proper screening as we go forward. I'm keen to follow up on this program and maybe even get the people from the George Institute on board to have a discussion about how we can rethink what relevant biomarkers are, because they said that this actually compares as well as, and some of the original cardiovascular disease risk biomarkers also came out of the George Institute, where age and cholesterol levels and activities. I mean, there's a whole bunch of things that play a role here. Heart disease is still one of the major killers in Australia. I think recently we published that dementia has now become number one, but cardiovascular disease, I think, is still number two. And for a younger population, it's still number one. It's still the major cause of death.
And for women, the signs and symptoms are different to men. And still, there's an ignorance about that in the community. Because in the movies, the guy grasps his chest and, oh, no, and his arm is sore and he falls to the ground and has a heart attack. But that's often not what women experience at all.
2 nights ago, the European Connected Health Alliance, who I'm associated with, has now changed its name to the Global Health Connector, by the way. They actually ran a session at the United Nations specifically on women's health. Now, unfortunately, it started at 11 p.m. and went through to 4 a.m. So I didn't listen to all of it, but I did log in for most of it. And that was one of the things most emphasized, was the fact that cardiovascular disease in women is still diagnosed 3 to 5 years later than it is in men. And the number of women who die of undiagnosed cardiovascular disease, not only in developed economies, but in developing economies, and in developing economies even more so, that it just doesn't even get picked up. I think from an equity perspective, from a gender perspective, it's important that we have new tools to pick this up, but also education for women to know that this is an issue and that they need to think about it early, and maybe it'll save lives and avoid some of the morbidities we've seen. Because the thing is with heart disease, it doesn't necessarily mean you have a heart attack and you drop dead. It often means that you end up with ongoing heart failure. And heart failure is a terrible disease to go through. The mortality rate of heart failure is actually higher than the mortality rate for breast cancer. So we are understanding that what we can do to manage these diseases. Great. So kudos to Claire Arnott and her team. And I'm looking forward to hearing more from the well-named George Institute for Global Health.
All right, great. And we'll put that out there, George. And let's get them on the show. That's a great idea. George, it's been great chewing the latest hot topics. For those of you who aren't in the studio with us, our list was a lot longer today, but, we try to get us to shut up. Talking about digital health is almost an impossibility. So we'll bring them to you in the next episode. George, did you have any recommendations for the Pulse Potties this week?
There's a lot happening at the moment in healthcare, a lot happening in digital health. There is an event coming up in Hong Kong where they'll be having an online forum on geron technology. I will send you a link, Louise. It's free online summit on geron technology coming up in mid-October. So other than that, keep your eyes open to read Pulse IT, where you can find the latest and greatest. Get your daily dose of Pulse IT. Every morning when I open up my email, I read my Pulse IT thread and it comes up with some interesting stories that I keep it to. Stay informed. Because in this era of misinformation, what they say in the world of the blind, the one-eyed man is king. Those who have information are the ones who can actually make sure we get things happening properly.
Yeah. Oh, that's a great shout out, George. And I'm just going to give a shout out for the clinician or Pulse Poddies who have clinician friends who are based in Australia. There's a job that you might be interested in. The Australian Digital Health Agency is refreshing their digital health advisor community. Applications are now open. I will put a link in the show notes. You know what to do, people. Our listeners are all about shaping the future of healthcare. So please do check out that link, and applications close on the 16th of October.
Yep. I've been a digital health advisor with the agency in the past, and it's a great way for us to have clinical input into the amazing work being done in Australia around digital health.
Yes, all about connected care, standards, policy. Yeah, if you want to shape the future. And that was actually back in, when was it? I was still living in Perth. I don't know, maybe it was 2007 or something, when there wasn't an agency. There was the National eHealth Transition Authority. I was one of their clinical advisors back in those days. So there you go. Become a clinical advisor. You might end up with a podcast on digital health one day. All your dreams will come true.
Yeah, it takes 20 years, but hey, it was 18 years for things to happen. So there you go. Sounds about right. 2007 to 2025. That's about right.
Yeah. All right. Well, good to always join you in the studio, George. I look forward to seeing you in the Gold Coast in a few days' time. In the meantime, can you please read us out?
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions, and a special thanks to Emily Mara for her support for the Pulse podcast over the last year. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. And don't forget, you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. Ciao.
Ciao, Bella.